So in our studies, it was a clinical utility study to assess the clinical utility of circulating tumor cell count to guide choice between hormone therapy, single agent hormone therapy versus chemotherapy in patients in first line of their metastatic breast cancer, hormone receptor positive to negative metastatic breast cancer. And basically what we found here is that in the overall study population, which is about 800 patients, the CTC test is reliable. So it means that if you don't know how to treat your patient, you can trust the CTC test to tell whether you should give hormone therapy first or a frontline chemotherapy according to the number of CTC you detect in the blood. So that was the general finding in the general population. And then we had subgroup analysis according to the different risk estimates according by the clinicians and according by the CTC count. So the first and important group, about half of our patients, so this patient had a clinical low risk profile. So clinicians were thinking to treat this patient with endocrine therapy. And when the CTC test was coming back with a low CTC count, with less than 5 CTC, what we observed first is an excellent PFS of 19 months, and this is about half of the study population. So it means that in patients or in countries with limited financial resources available, then that test might be able to pick patients with excellent PFS, with single agent hormone therapy without the use of CDK4/6 inhibitors. And then in patients for which CTC test is high, so more than 5 CTC, what our study found is that there is an advantage in terms of progression-free survival, but also overall survival, favoring frontline chemotherapy followed by maintenance hormone therapy. And this is a really new result because for a long time we considered that chemotherapy was no better than endocrine therapy, but these trials were performed in the general population. And here with the CTC test, we are able to pick subgroups that are at higher risk of early progression and for which chemotherapy was apparently better. Most of our patients were treated, so our patients were, patients in our study did not receive CDK4/6 inhibitors as a first-line therapy, but most of them received CDK4/6 inhibitors in a more advanced setting. And so far, CDK4/6 inhibitors have not demonstrated that they improve the overall survival of patients when given in first line. But if you consider that the currently CDK4/6 inhibitors are becoming mainstream in first line, then again, patients with low CTC count, these patients have a very good progression-free survival. So if the financial toxicity of CDK4/6 inhibitor is a concern for your patient or in your country, then this test might help you to distinguish half of the patient population that have excellent PFS without CDK4/6 inhibitors. On the other side, which is the escalation side, so at some point in the future, we'll try to beat CDK4/6 inhibitors by adding another drug, for example, or by testing new drugs. And then we'll probably have to test it first, patient at high risk of disease progression, and then our studies strongly suggest that we will have to use CTC count to pick this high-risk patient as a selection criteria to test the new drugs to come.